Medications used in COPD treatment. Bronchodilator medications are central to symptom management in COPD. Inhaled therapy is preferred. The choice between beta-2 agonist, anticholinergic, and theophylline or combination therapy depends on availability and individual patient response in terms of symptom relief and side effects. Bronchodilators are prescribed on an as-needed or on a regular basis to prevent or reduce symptoms. Long-acting inhaled bronchodilators are convenient and more effective at producing maintained symptom relief than short-acting bronchodilators. Combining bronchodilators of different pharmacological classes may improve efficacy and decrease the risk of side effects compared to increasing the dose of a single bronchodilator. Theophylline, the most commonly used methyloxamine, is metabolized by cytochrome P450 mixed function oxidases. Clearance of the drug declines with age. Theophylline is less effective and less well tolerated than inhaled long-acting bronchodilators and is not recommended. Those drugs are available and affordable. Adverse effects include the development of atrial and ventricular arrhythmias and grand mal convulsions. Other side effects include headaches, insomnia, nausea. Regular treatment with inhaled corticosteroids improves symptoms, lung function, and quality of life, and reduces the frequency of exacerbation in COPD patients with an FEV1 less than 60% predicted. In inhaled corticosteroid combined with a long-acting beta-2 agonist is more effective than the individual components is in improving lung function and health status and reducing exacerbation in patients with moderate to very severe COPD. The principal action of phosphodiesterase 4 inhibitors is to reduce inflammation by inhibiting of the breakdown of intracellular cyclic AMP. It's a once daily oral medication with no direct bronchodilator activity. Roflumilast reduces moderate and severe exacerbations treated with corticosteroids by 20% in patients with chronic bronchitis, severe to very severe COPD, and a history of exacerbation. The goal of COPD management is to improve a patient's functional status and quality of life by preserving optimal lung function, improving symptoms, and preventing the recurrence of exacerbations. Approaches to management include recommendations such as those provided by GOLD. Stage 1. Reduction of risk factors. Short-acting bronchodilator is as needed. Stage 2. Reduction of risk factors. Short-acting bronchodilator is needed. Long-acting bronchodilator. Cardiopulmonary rehabilitation. Stage 3. A reduction of risk factors. A short-acting bronchodilator is needed. Long-acting bronchodilator, cardiopulmonary rehabilitation, inhaled glucocorticoids, and repeated exacerbation. If repeated exacerbation. Stage 4, reduction of risk factors. Short-acting bronchodilator is as needed. Long-acting bronchodilator, cardiopulmonary rehabilitation, inhaled glucocorticoids, and if repeated exacerbation. Long-term oxygen therapy. Consider surgical options such as LVRS and lung transplantation. Oxygen therapy. Prescription of supplemental oxygen to COPD patients. Arterial hypoxemia defined as PaO2 less than 55 milligram 55 mmHg or CO2 less than 88%. Prescribe supplemental oxygen and titrate to keep CO2 more than 90%. Recheck in 60 to 90 days to assess if supplemental oxygen is still indicated, if prescribed supplemental oxygen is effective. Surgical COPD treatment. Interventional therapy in stable COPD. Lung volume reduction surgery. Lung volume reduction surgery improves survival in severe emphysema patients with an upper lobe emphysema and low post-rehabilitation exercise capacity. Bulectomy. In selected patients, bulectomy is associated with decreased dyspnea, improved lung function, and exercise tolerance. Transplantation. In appropriately selected patients with very severe COPD, lung transplantation has been shown to improve quality of life and functional capacity. Bronchoscopic intervention. In select patients with advanced emphysema, bronchoscopic interventions reduce expiratory lung volume and improve exercise tolerance, health status, and lung function at 6-12 months following treatment. And the bronchial valves, lung coils, fibroablation. Treatment of acute exacerbation of COPD. An exacerbation of COPD is an acute event characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variation and leads to a change in medication. Diagnosis. Currently, the diagnosis of an exacerbation relies exclusively on the clinical presentation of the patient's complaining of an acute change of symptoms that is beyond normal day-to-day variation. The goals of treatment for COPD exacerbations are to minimize the negative impact of the current exacerbation and prevent the development of subsequent events. Depending on the severity of an exacerbation and the severity of the underlying disease, and exacerbation can be managed in either the outpatient or inpatient setting. More than 80% of exacerbations are managed on an outpatient basis with pharmacological therapies, including bronchodilators, corticosteroids, and antibiotics. Treatment. of acute exacerbation. Key points for the management of exacerbation. Short-acting inhaled beta-2 agonist with or without short-acting anticholinergics are recommended as the initial bronchodilators to treat an acute exacerbation. Systemic corticosteroids can improve lung function, oxygenation, and shorten recovery time and hospitalization duration. Duration of therapy should not be more than 5-7 days. Antibiotics, when indicated, can shorten recovery time, reduce the risk of early relapse, treatment failure, and hospitalization duration. Duration of therapy should be 5-7 days. Methoxantins are not recommended due to increased side effects profiles. Non-invasive mechanical ventilation should be the first mode of ventilation used in COPD patients with acute respiratory failure who have no absolute contraindication because it improves gas exchange, reduce work of breathing and the need for intubation, decrease hospitalization duration, and improves survival. Asthma is a common and bronchial asthma. The next topic. Asthma is a common and potentially serious chronic disease that imposes a substantial burden of patients, their families, and the community. It causes respiratory symptoms, limitation of activity, and flare-ups that sometimes require urgent health care and may be fatal. Asthma affects 5-10% of the population, or an estimated 23.4 million persons, including 7 million children. The overall prevalence rate of exercise-induced bronchospasm is 3-10% of the general population. If persons who don't have asthma or allergy are included, but the rate increases to 12-15% of the general population if patients with underlying asthma are included. Asthma affects an estimated 300 million individuals worldwide. Annually, the World Health Organization has estimated that 15 million disability adjusted life years are lost and 250,000 asthma deaths are reported worldwide. Factors that can contribute to asthma or airway hyperactivity may include any of the following: environmental allergens, viral respiratory tract infections, exercise hyperventilation, gastroesophageal reflux disease, chronic sinusitis or rhinitis, aspirin or non-steroidal anti-inflammatory drug, hypersensitivity, sulfite sensitivity, the use of beta adrenergic receptor blockers, obesity, and environmental pollutants, tobacco smoke, occupational exposure, irritants, various high and low molecular weight compounds, emotional factors or stress, perinatal factors. Chronic inflammation of the airways is associated with increased bronchial hyperresponsiveness, which leads to bronchospasm and typical symptoms of wheezing, shortness of breath, and coughing after exposure to allergens, environmental irritants, viruses, cold air, or exercise. In some patients with chronic asthma, airflow limitation may be only partially reversible because of airway remodeling that occurs with chronic untreated disease. Airway inflammation in asthma may represent a loss of normal balance between two opposing populations of T lymphocytes. Two types of T lymphocytes have been characterized, T1 and T2. T1 cells produce interleukin-2 and IVN alpha, which are critical in cellular defense mechanisms in response to infection. T2, in contrast, generates a family of cytokines that can mediate allergic inflammation. Airflow obstruction can be caused by a variety of changes, including acute bronchoconstriction, airway edema, chronic mucous plaque formation, and airway remodeling. Acute bronchoconstriction is a consequence of immunoglobulin E dependent mediator release upon exposure to allergens and is a primary component of the early asthmatic response. Airway edema occurs 24 hours following an allergen challenge and is referred to as the late asthmatic response. Chronic mucous plaque formation consists of an exudate of serum proteins and cells debris that may take weeks to resolve. Airway remodeling is associated with structural changes due to long-standing inflammation and may profoundly affect the extent of reversibility of airway obstruction. Airway obstruction causes increased resistance to airflow and decreased expiratory flow rates. These changes lead to a decreased ability to expel air and may result in hyperinflation. Morphology of bronchial asthma growth. Lungs are overdistended due to overinflation. Small areas of atelectasis can be seen. Occlusion of bronchi and bronchioles by thick tenacious mucus plaque. Most striking finding. Hyperinflation compensates for the airflow obstruction, but this compensation is limited when the tidal volume approaches the volume of the pulmonary dead space. The result is alveolar hyperventilation. Vasoconstriction due to alveolar hypoxia also contributes to this mismatch. Vasoconstriction is also considered an adaptive response to ventilation perfusion mismatch. In the early stages, when ventilation perfusion mismatch results in hypoxia, hypercarbia is prevented by the ready diffusion of carbon dioxide across alveolar capillary membranes. Thus, patients with asthma who are in the early stages of an acute episode have hypoxemia in the absence of carbon dioxide retention. Hyperventilation triggered by the hypoxic drive also causes a decrease in PaCO2. An increase in alveolar ventilation in the early stages of an acute exacerbation prevents hypercarbia. This fostering obstruction and increase in ventilation perfusion mismatch, carbon dioxide retention occurs. In the early stages of an acute episode, respiratory alkalosis results from hyperventilation. Later, the increased work of breathing, increased oxygen consumption, and increased cardiac output result in metabolic acidosis. Respiratory failure leads to respiratory acidosis due to retention of carbon dioxide as alveolar ventilation decreases. Asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It's defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity together with variable expiratory airflow limitation. History. A detailed assessment of the medical history should address the following: whether symptoms are attributable to asthma, whether findings support the likelihood of asthma severity, identification of possible precipitation factors. Family history may be pertinent for asthma, allergy, sinusitis, rhinitis, eczema, and nasal polyps. The social history may include home characteristics, smoking, workplace or school characteristics, educational level, employment, social support factors that may contribute to non-adherence and asthma medications and illicit drug use. The patient's exacerbation history is important with respect to the following: usual prodromal signs or symptoms, rapidity of onset, associated illnesses, number in the last year, need for emergency department visits, hospitalization, ICU admissions, intubations, missed day from work or school, or activity limitation. Many clinical phenotypes of asthma have been identified. Some of the most common include allergic asthma. This is the most easily recognized asthma phenotype, which often commences in childhood and is associated with a past and family history of allergic disease, such as eczema, allergic rhinitis, or food or drug allergy. Examination of the induced sputum of this patient before treatment often reveals eosinophilic airway inflammation. Patients with this asthma phenotype usually respond well to inhaled corticosteroid treatment. Non-allergic asthma. Some patients have asthma that is not associated with allergy. The cellular profile of the sputum of these patients may be neutrophilic, eosinophilic, or contain only a few inflammatory cells. Patients with non-allergic asthma often demonstrate less short-term response to ICS. Adult onset asthma. Some adults, particularly women, present with asthma for the first time in adult life. These patients tend to be non-allergic and often require higher doses of ICS or relatively refractory to corticosteroid treatment. Occupation asthma should be ruled out in patients presenting with adult onset asthma. Asthma with persistent airflow limitation. Some patients with long-standing asthma develop airflow limitation that is persistent or incompletely reversible. This is thought to be due to airway wall remodeling. Asthma with obesity. Some obese patients with asthma have prominent respiratory symptoms and little eosinophilic airway inflammation. Asthma severity is defined as the intensity of the disease process prior to initiating therapy and helps in determining the initiating of therapy in a patient who is not on any control of medications. Now you can hear the sounds of the lung. Wheezing, a musical high-pitched whistling sounds produced by airflow turbulence, is one of the most common symptoms. In the metasphere form, wheezing is only anti-expiratory. As severity increases, the wheeze lasts through expiration. In a more severe asthmatic episode, wheezing is also present during inspiration. During wheezing may be absent because of the severe limitation or of airflow associated with airway narrowing and respiratory muscle fatigue. Asthma can occur without wheezing when obstruction involves predominantly the small airways. Patients with vocal cord dysfunction, now referred to as intaxable laryngeal obstruction, have a predominantly inspiratory monophonic wheeze, which is heard best over the laryngeal area in the neck. Patients with excessive dynamic airway collapse, bronchomalacia, or tracheomalacia, or also have an expiratory monophonic wheeze heard over the large airways. In exercise included bronchoconstriction, wheezing may be present after exercise, and in nocturnal asthma, wheezing is present during the night. Cough may be the only symptom of asthma, especially in cases of exercise included or nocturnal asthma. Usually the cough is non-productive and non-paroxysmal. Chest tightness or a history of tightness or pain in the chest may be present with or without other symptoms of asthma, especially the exercise included or nocturnal asthma. Typical symptoms include cough, wheezing, shortness of breath, and chest pain or tightness. Patients may note asthma symptoms are related to seasonal changes of the ambient temperature and humidity in the environment in which a patient exercises. Other triggers may be pollutions, pollutants, or upper respiratory tract infections. Cold, dry air generally provokes more obstructions than warm, humid air. Physical examination. Signs of atopy or allergic rhinitis, such as conjunctival congestion and inflammation, ocular shiners, and transverse crease on the nose due to constant rubbing associated with allergic rhinitis, and pale violaceous nasal mucosa due to allergic rhinitis may be present in the absence of an acute episode, such as during an outpatient visit between acute episodes. Turbinates may be erythematous or buggy. Polyps may be present. Skin examination may reveal atopic dermatitis, eczema, or other manifestations of allergic skin conditions. Clubbing of the fingers is not a feature of asthma and indicates a need for more extensive evaluation and workup to include other conditions, such as cystic fibrosis. A large percentage of patients with asthma experience nocturnal symptoms once or twice a month. Some patients only experience symptoms at night and have normal pulmonary function in the daytime. This is due in part to the exaggerated response to the normal circadian variation in airflow. Bronchoconstriction is highest between the hours of 4 a.m. and 6 a.m. These patients may have a more significant decrease in cortisol levels or increased vagal tone at night. Studies also show an increase in inflammation compared with controls and with patients with daytime asthma. Laboratory assessment and studies are not routinely indicated for the diagnosis of asthma, but they may be used to exclude other diagnoses. Eosinophilia and elevated serum immunoglobulin E levels may help guide therapy in some cases. Arterial blood gases pulse oximetry are available for assessing severity of exacerbation and following response to treatment. Total serum immunoglobulin E levels greater than 100 IU are frequently observed in patients experiencing allergic reaction. But this finding is not specific for asthma and may be observed in patients with other conditions. A normal total serum immunoglobulin E level does not exclude the diagnosis of asthma. Elevated serum immunoglobulin E levels are required for chronic asthma patients to be treated with omalizumab. Blood eosinophilia greater than 4% or 300-400 nanoliter supports the diagnosis of asthma, but an absence of this finding is not exclusionary. Eosinophil counts greater than 8% may be observed in patients with concomitant atopic dermatitis. This finding should prompt an evaluation for allergic bronchopulmonary aspergillosis, Church-Strauss syndrome, or eosinophilic pneumonia. Arterial blood gas measurement provides important information in acute asthma. This test may reveal dangerous levels of hypoxemia or hypercarbia secondary to hyperventilation and hence respiratory acidosis. However, the typical finding in the early stages of an acute episode is respiratory alkalosis. Venous levels of PCO2 have been tested as a substitute for arterial measurement, and a venous PCO2 greater than 45 millimeter may serve as a screening test, but cannot substitute for the ABD. Sputum analysis. Microscopic. Mucus plug contain walls of shed epithelium, numerous eosinophils, and Charlotte Leyden crystals. Crystals made of eosinophil proteins are also present. Pulse oximetry measurement is desirable in all patients with acute asthma to exclude hypoxemia. The hypoxemia of uncomplicated acute asthma is readily reversible by oxygen administration. Allergy skin testing is a useful adjunct in individuals with atopy. Results help guide indoor allergen mitigation of or help diagnose allergic rhinitis symptoms. The allergens that most commonly cause asthma are aeroallergens such as house dust, mites, animal denders, pollens, and mold spores. Chest radiography. The chest radiograph remains the initial imaging evaluation in most individuals with symptoms of asthma. In most patients with asthma, chest radiography findings are normal or may indicate hyperinflation. Reported features with asthma include pulmonary hyperinflation, bronchial wall thickening, peribronchial coughing, pulmonary edema due to asthma. Goals of asthma management. The long-term goals of asthma management are to achieve good symptoms control and to minimize future risk of asthma-related mortality, exacerbation, persistent airflow limitation, and side effects of treatment. The patient's own goals regarding their asthma and its treated should also be identified. The patient health professional partnership. Effective asthma management requires a partnership between the person with asthma and their healthcare providers. Teaching communication skills to healthcare providers may lead to increased patient satisfaction, better health outcomes, and reduced use of healthcare resources. The patient's health literacy, that is the patient's ability to obtain, process, and understand basic health information to make appropriate health decisions, should be taken into account. Quick relief medications are used to relieve acute asthma exacerbation and to prevent exercise, include bronchoconstriction symptoms. Controllers medication are used to control known asthma symptoms and their severity. Preventers medication are used to prevent progression of disease and complication appearance. Signs of severe exacerbation of asthma. The presence of certain clinical findings may help to identify patients experiencing severe asthma attacks and are indicative of severe airflow obstruction, tachypnea, tachycardia, use of accessory muscles of inspiration, inability to speak in full sentences or phrases, inability to lie supine due to healthlessness, and pulsus paradoxus. Thank you for attention. Goodbye.